Hello, everyone. Welcome to the webinar, Common Data Elements for Workforce and Staffing in International Long-Term Care Research. The webinar is being recorded and will be posted on the GSA website. A notice to all attendees will be distributed once the recording is available. A question and answer session will immediately follow the live presentation. We will be accepting questions through the questions feature accessible on the GoToWebinar panel. Also located there are downloadable handouts for today, a copy of the presentation slides. The presentation will be given by Charlene Chu, Assistant Professor in the Lawrence S. Bloomberg Faculty of Nursing at the University of Toronto, Canada. Also Franziska Zuniga, Head of Education in the Institute for Nursing Sciences, Department of Public Health at University of Basel, Switzerland. And Michael Lepore, Vice President of the Live Well Institute and Adjunct Assistant Professor of Health Services Policy and Practice at Brown University in Providence, Rhode Island, USA. Before we dive into the program, I'll ask the audience to tell us who you are by answering the poll that appears on your screen. So you should find there now question that says, please tell us who you are. If you could make your selection now, that would be very helpful. Thank you. And I will give just another second and close it and share what the results are so our presenters can see. And here are the results. There we got it. Okay, so without further delay, I will hand the microphone over to Michael.
Thank you, Judy, and welcome all. And thanks also to GSA for providing this opportunity to share our work. As indicated in Judy's introduction, this webinar addresses the international measurement of long-term care workforce and staffing issues. To get us started, I'll briefly describe We Thrive, which is a collaborative research initiative that has been building toward international common data elements for long-term care. And next, Drs. Zuniga and Chu, who are both We Thrive steering committee members and collaborators since the initiative launched at GSA in 2016, will review work conducted to identify international common data elements for 3 long-term care workforce and staffing concepts. And finally, we will have a discussion and question and answer period. We go to the next slide, please. As a brief background, we do recognize that international long-term care research can valuably inform national policy and long-term care practice, but limited international data on long-term care currently restricts the contributions of research to shaping long-term care policy and practice. Better international long-term care data sharing and aggregation can be a public health boon, but the selection of the specific data elements that are collected internationally must be carefully considered. Next slide, please. We Thrive has specifically sought to identify common data elements that can be implemented internationally for the purpose of supporting and measuring person-centered long-term care and healthy aging outcomes. And over the past several months, we've grappled with the ongoing importance of person-centered care and healthy aging outcomes, even during the current pandemic. We go to the next slide. A recent We Thrive article in JAMDA, for example, emphasizes the issue of chronic understaffing in long-term care, which has made providing basic care a challenge and monitoring residents for symptoms even more difficult, and has undermined the ability of staff to follow protocols to keep residents physically distant. We examine in this piece how the precarity of long-term care work, including low wages, heavy workloads, and punitive measures related to sick time, all contribute to the global long-term care staffing crisis and to the COVID-19 pandemic. Next slide. But even within this pandemic, context, WeThrive's focus has remained on supporting healthy aging outcomes through person-centered long-term care and strengths-based approaches, and ultimately on creating or co-creating a measurement approach using internationally shared common data elements. We can go to that next slide. And by allowing for standardized, consistent data collection, common data elements can improve data quality and facilitate data sharing and aggregation, while also improving opportunities for meta-analyses and international or cross-study comparisons. And ultimately, these sorts of common data elements can make long-term care research more efficient overall. That's the next slide. So to date, WeThrive has prioritized 4 domains of international long-term care measurement, and within each of those 4 domains, several concepts for measurement within each. And today, we're specifically focused on that workforce and staffing domain. We could go on to that next slide. So within this domain today, we will specifically focus on staff retention and turnover, supervisory effectiveness, and staff training. And we could just actually go on to the next slide at this point. But before passing the baton to Dr. Zuniga, I also would note that a growing series of open access articles from our work is available in a special collection on international common data elements for residential long-term care. And these are in the journal Gerontology and Geriatric Medicine. But other than that, I think we can now go on to the next slide, and I'd invite Dr. Francisca Zuniga to share the team's work on staff retention and turnover.
Thank you very much for giving me the word. I have the pleasure to present you a common data element for the concept of retention and turnover, or as you will see, basically on the measurement of intention to stay. And I would just like first to acknowledge all the co-authors and members of this working group who greatly supported the development of this measurement in many discussions. And we published the final version in this Gerontology and Geriatric Medicine journal. Next slide, please. So one of the great challenges that we also, especially now in this COVID-19 or pandemic time, have seen is how do we maintain capacity in residential long-term care, also given the increasing frailty and dependency, both functional and cognitive impairment of the residents we have. And with this increase, unfortunately, financial regulations or also care models don't go with the changes. So we do have increasing care to provide to residents, but with the same finances. That's a problem we are facing. And often it's just possible to provide the routine care, but as soon as we get out of this of the routine, it's really a challenge to have both the sufficient number and competent workforce needed for this frail population. So if we look at how can we build capacity in the residential long-term care sector, there are things that can be done overall, like increase entries in nursing education, increase the attractivity of the profession, having more nurses on the market, but still this doesn't automatically lead to more nurses in long-term care. We can also promote reinsertion in workforce, especially for nurses after motherhood to get back to work and get again into what it means to work with older persons. But there are also things that can be done by the long-term care facilities themselves, which have to do with how to maintain staff and how to prevent turnover. Next slide, please. So this stay or leave are basically two sides of a coin. And if we first look at this retention or intention to stay, the stability of staff is actually very important to be able to provide good quality care, because stability allows staff to build long-term relationships with residents and families. They get to know the person much better, their habits, their routines. They are quicker in noticing changing, in realizing, oh, there might be an infection coming, which is often not don't have the typical symptoms. So basically what stability of staff also allows or gives the ground for is providing person-centered care. It also allows to retain facility-specific knowledge, that these procedures and processes in the facility are clear. And if they are clear, I can really free resources to dedicate to the resident. We know about influencing factors from studies, so we know where staff feel empowered or have leadership that really supervise them with support. And if they have a work environment that allows them or gives them the possibility to provide good quality of care, there's a higher probability that this staff will stay in this nursing home. Intention to leave or turnover, on the other hand, means there's a change in staff. There's new recruitment, there are temporary replacements who do not know residents that well. It's a reduced productivity because the routines are not clear, procedures are not clear. It's of course costly due to the administrative costs that are involved in recruitment. And more importantly, there's also this problem for cognitively impaired residents. With the constantly changing staff, they get more disoriented because on the one hand, staff don't know them, but they don't get lost in this constant, in this loss of stability. So turnover is also known to be related to poor resident outcomes. Influencing factors are different. So it's work staff, care workers with burnout, with job dissatisfaction, who have a higher intention to leave. And if we compare these two concepts, we see they are different and they have different influencing factors. And we also know that if we just eliminate factors related to intention to leave, this will not automatically lead employees to stay, because if there's less work stress, that doesn't automatically mean that I have good support, that I feel empowered in my work environment. Next slide. So when we were looking at how could we measure this, how could we measure it internationally, we had first the selection between, so do we go for retention or intention to stay, or do we go for turnover, intention to leave? And We Thrive as a group focuses on capacity, on this thriving of residents and of staff. So just based on this focus, we decided to measure retention rather than turnover. And the other selection was, so if we look at these concepts, the retention and turnover questions are rather measured at facility level, often with administrative data or with survey of administrators, while the intention to stay or intention to leave, this is something I have to ask staff at the individual level. I have to do a survey and ask, do you intend to stay? Do you intend to leave? And when discussing this in this workforce group, we said, it's really a challenge to find international data at administrative level that is comparable. So whatever a residential facility in the US or in Canada measure is not the same as the one in Switzerland or in Taiwan or in Morocco. So that makes it difficult to actually be able to compare data at the administrative level or facility level. So we decided to go for a measure at individual level. In the end, and that would be on the next slide, we looked at the literature, what kind of measurements are out there. And we found 5 studies who measure intention to stay, 4 of them with single items with different kind of questions. The first, do you want to continue working in your current workplace, with basically a yes or no or don't know answer, or how likely is it that you will continue working at this facility for the next 5 years. So here there was also a time limit in the question of McGilton and colleagues. Then we have, I intend to remain in my current position for the near future, or the last option, from now on, how many years will you stay in the long-term care industry? So more open question. When we discussed all these questions, we then came up with a solution or a proposition of how to measure it, which is shown on the next slide, where we say we would measure, I intend to stay in this organization for the next 12 months with an agreement scale. Could you click once more? So the reason for single item measure was, on the one hand, the lower questionnaire burden. This single item, it can be easily introduced in other questionnaire surveys. We also said we want to include time period for clarity, because if we say the near future or the next time, that can be interpreted very differently by staff, but 12 months seems more clear. And we also went for 12 months and not 5 years, because the LTC market is moving fast. We also would suggest to include all staff in the survey. There can always be sub-analysis afterwards for comparison between registered nurses or licensed practical nurses or care aides, to look at it more in detail, although there we have the whole difficulty that these different professions are differently classified in different countries. What is still open now is, this is a single item and it's in English now. It needs to be translated to be tested in different countries, and we still have to assess the relevance of staff stability in lower middle income countries. We know less about that because we didn't find it in the literature, what is being said about staff stability in LTC in low and middle income countries, expecting that it is actually something that is internationally relevant. So this is the item we suggest. That's basically the main message of the paper and of this part of the presentation, that we would suggest this measure. And in the next step, we would also like to do a quick poll with you, in the sense of, what do you think about this measurement? Do you think this is applicable in my country? Do you think, yes, it's okay, but not applicable? You would prefer to rather measure turnover, intention to leave, that's more important. You would rather go on the administrative data level than on employee survey, or you'd say, don't measure this with one item, do it with several items. Please vote.
Right, it looks like people are clicking, so I will give 2 more seconds and we'll close it. Here we go. And then I'll share the results, which you should see now.
Thank you very much. I think we will discuss this in the end if there are questions around this. And I would like to give the word to Charlene Chu.
Thank you so much, Francisca, and also welcome everybody. So I'll be covering the second and the third concepts. The second concept we will be presenting here today under the workforce and staffing domain is evaluating supervisory effectiveness in long-term care. So this work has been led by Dr. Catherine McGilton from Toronto Rehab Institute and the Faculty of Nursing at the University of Toronto in Canada. This is an international team, as Francisca has mentioned, including those from the UK, Spain, Switzerland, Sweden, as well as other researchers in Canada. And this work has been submitted to the Gerontology and Geriatric Medicine and will also be included in the special issue that Michael mentioned earlier on in our slide deck. And this work is currently under review. Next slide, Judy. Okay, so I we'll first like to perhaps introduce the topic of supervisory effectiveness, and then I'll follow up with the design and the results of Dr. McJilton's study. So supervisors in long-term care are nurses. They're either registered nurses, registered practical nurses, or licensed practical nurses, and they oversee the activities of nursing assistants who report directly to them. And supervisors are very important because they primarily determine if long-term care workers feel valued and respected, and there's a lot of qualitative research that has demonstrated this. An integrative review that Dr. McJilton and I have conducted in the past identified common attributes and processes of effective supervisors. And these include things like whether or not supervisors were active listeners to their employees, were they able to be flexible, communicate information clearly in an accurate way, were they being open to their staff, did they demonstrate supportive behaviors, and were they being understanding to their staff, or do their staff have the perception that their supervisors were understanding? And effective supervisors have also been associated with a number of benefits as well as positive outcomes that have been quantified in the past as well. So these include things like an increased quality of long-term care environments, an improved nursing assistant job satisfaction, as well as reduced intent to turnover. And it also helps support staff feel like they can espouse a more resident-centered approach. Next slide, Judy. Thank you. So in this work, the aim was to identify tools to measure supervisory effectiveness within long-term care settings in order to inform the CDEs that would allow the aggregation of data across countries. And so this was done in 2 phases in order to identify these tools. The first phase was a literature review. So we used we worked with an information specialist in order to look at the data between 2000 and 2019 from several electronic databases. We used relevant key search terms suggested by the We Thrive group, as well as our information specialist. And then it is worth mentioning that the results were also limited in English. And then the second phase was we proceeded with a ranking process and the selection of the candidate measures. So here, 2 reviewers independently analyzed the results of the literature review, and then by using the inclusion and exclusion criteria, we identified 11 measurement tools. From these 11 measurement tools, 2 were removed retroactively because they were not financially accessible to long-term care settings in low-income countries. And so this didn't complement with the We Thrive values. So those 2 were removed, and then that left us with 9 tools. These remaining 9 tools were then entered into a spreadsheet along with detailed information about each tool, and then a copy of the tool into the package. And then this package was circulated to the members of the We Thrive subgroup to review. Next slide, please. So members were asked to individually review the 9 measures and then rank the measures from 1 to 9 based on several important parameters that were deemed critical for international comparison research. So this included whether or not the elements of the scale, if the items seemed relevant, if the scales came in different languages, were the psychometric properties of the scales strong, what were the logistical aspects of the scale, if there were any financial costs associated to using the scale, how difficult it would be to complete the measure, and then scale outcomes as well. Next slide, please. So here's a list of the 9 tools that were under consideration that the panel reviewed and ranked. So the first is the Direct Care Staff Survey Instrument, then the Job Role Quality Questionnaire, Supervision Subscales, the Leadership Behavior Questionnaire, the Relationship Between Management Practice Index, the Psychological Distress Survey, Relationship, Staffing, and Quality of Care in Nursing Homes, Benjamin Rose Relationship, with Supervisor Scale, the Supportive Supervisory Scale, and the LEAP Survey, the leadership, specifically the Leadership Behavior Subscale. Next slide, please. Thank you. So after the ranking and selection process, there were 3 top ranked measures. So these were the Benjamin Rose relationship with supervisor scale, the supportive supervisory scale, and then the LEAP survey, specifically the leadership and behavior subscale. Can you just click one more time? Thank you. And so I'll add here that since the conduction of this review, the supportive supervisory scale has also been translated into Chinese and has been and has demonstrated preliminary construct validation. And so after we had reached the final rankings of these 3, upon further discussion within the expert panel, we came to a consensus that because the Benjamin Rose relationship with supervisor scale required permission to be used, that usability might be less feasible because it would be dependent upon the author's willingness to agree to use this scale. So the expert panel then would formally recommend that these 2 ranked measures, the supportive supervisory scale, as well as the LEAP survey, specifically the relationship behavior subscale, be used as the candidate CDE measures, and that the authors encourage use of these measures to generate comparable global data and to measure supervisory effectiveness. Next slide, please. So we looked then across the 3 measures to try to see if we could find any commonalities between them. And what we noticed were that all 3 measures were Likert type scales. And second, when we looked at the individual items to see if there were commonalities between how supervisory effectiveness was being measured, what we noticed were that many of the items referred to things about whether or not supervisors were attentive listeners, if they gave recognition, if they gave praise, if they vocalized appreciation, the encouragement of individual growth, and whether or not they encourage staff to apply themselves fully in their jobs, and the receptiveness to staff concerns and ideas. The strengths of this approach is that we used an international and multidisciplinary expert review panel that spanned various countries, and that the authors of this article come from a variety of academic and experiential backgrounds, and so we were able to consider the measures in a number of different contexts, and then eventually agree on CDEs. But our systematic approach was also would also lend to the strength and robustness of this process. And we believe that the CDEs that we captured are appropriate. Next slide, please. However, there are some limitations as well that I just do want to touch on. So firstly, the systematic process of identifying these candidate measures was based on a limited number of search items, and we only included articles that were published in English. So therefore, there is a risk that not all possible measures appropriate for this research may have been included in this review. And while this risk is partially mediated by the fact that English is a major language spoken across the globe, it does highlight a need for further research to identify additional measures in other languages. Another limitation is that the expert panel of reviewers does not represent all long-term care settings internationally, because we do not have representation from places like Africa, Asia, Australia, or South America. And so this lack of inclusivity and actually how to go about achieving inclusivity is a common challenge to international research. And then with respect to next steps and future research, more work is needed to explore the usefulness of these CDEs from the perspective of long-term care providers and other low and middle income countries that are non-English speaking. So next slide, please. So we have a poll here, and we really have 2 questions, and it's just to find out whether supervisors are as important in other parts of the world, and whether people think it's important to include supervisory effectiveness as a core data element.
Great. I think people are voting. I'll just give a couple more seconds and close. We've got a good proportion of the audience clicking here. And here are the results.
Fantastic. It is important. Great. And then our next question is long-term care supervisor effectiveness sufficiently important to collect data on internationally? So please select one, yes, not sure, or no. Although I suspect if the answer for the first one was yes, then anyways, we'll see what comes up.
Anticipation. Yeah, people are voting, so I just want to give another second or two, and I'll close it in just another moment. There we go. That's the percentage I wanted. Here we go.
Okay, great. Thank you so much. Okay, so this is the last concept we'll be covering today in our workforce and staffing domain. So this is the Frontline Staff Training, which is our final concept. So I'm leading this paper with members of the subgroup committee, again, from all around the world. And this is a paper that's in its final stages and about to be submitted. So I acknowledge everybody's work and thank you very much. Next slide, please. So again, I'll introduce the concept and then describe the design and the results of this particular study and this work. So when we're speaking about training, what I'm referring to is the focused teaching provided by an institution that imparts a specific set of skills to operational employees. So training aims to augment and enhance individuals' knowledge, understanding, behavior, skills, values, their beliefs, while serving several important functions. And so this also includes attracting people to long-term care jobs. Training and other opportunities for professional development can help improve the poor image of jobs in long-term care homes, thereby attracting and retaining more people in the sector. The quality of long-term care relies on the staff's attitudes and skills and their knowledge. So shortcomings in any of these areas can lead to worsening care outcomes for long-term care homes. And so accordingly, research does show that staff training is the most widely accepted method to increase not only staff resiliency, but also the capacity of staff in order to provide high quality care within care homes. And it also enhances the psychological well-being of staff with broad-reaching benefits for residents. So for example, for staff, training provides a heightened sense of being able to provide quality care. They feel more confident and more knowledgeable. And so these feelings have been closely linked with job satisfaction. And so based on the literature, it is clear that research about training and access to training is a very important concept that helps to support workforce and staffing, and that bolsters staff's ability to provide care. Next slide, please. So when it comes to training, there's a lot of differences in training. And for example, the content of the training, who gets trained, or the job categories of who gets trained, the long-term care services offered by each individual home, might require training in a specific area. And so because there are so many different kinds of training and so many variations, it makes it very difficult to compare training programs, even between homes. And then when you extrapolate that to within regions or within countries or between countries, internationally, it's really difficult to sort of look at the experiences and outcomes of long-term care training internationally. And so more about sort of the differences between them and the heterogeneous nature of the long-term care training is that it can also, account for specific cultures, different geographical variations. For anybody who is doing research in long-term care. Much of the staff training is in the form of sort of in-services, lunch and learn, sort of on-the-job training, and previous work has shown that there's a huge range between a single 45-minute didactic session to 13 weeks of training. And so, and many of the training might not even be evaluated beyond what did you think of the facilitator, or did you like this training? And so from a methodological standpoint, this heterogeneity prevents the large aggregation of data in order to build cross-country evidence about staff training. So what kind of training and whether or not that training is effective. Further, there is no minimum international standard for long-term care training. And so again, we're unable to compare across countries. And so research that's trying to look at training broadly between countries is limited. And so there is a gap in the knowledge there. And so that's what we are trying to address here. And this leaves us in a place where, because it's difficult to compare within countries, between countries, it's hard to even know whether or not training happens, let alone what kind of training people are receiving. Next slide, please. Thank you. So as a critical first step to measure, for a critical first step to develop a small number of candidate CDE items that are ecologically viable to measure staff training and enable international comparative research in long-term care, the team used a scoping review with the aim to develop a standardized approach to evaluate training programs globally. And so we looked at several electronic databases and also included a secondary search. The search was limited to English, and if it was published between 2000 and 2020. Again, our search terms were established with the help of the We Thrive subgroup, as well as an information specialist. And then for our inclusion criteria, we looked specifically at studies that provided training to clinical staff or staff that were providing direct resident care in long-term care home settings. So for example, training that was provided for the IT staff or for administrators, those types of studies were excluded. And studies also needed to have a quantitative or some type of structured evaluation of the training, because we are looking at measurement approaches. And so any studies that included only a short interview after training, those were excluded as well. And then we had 2 reviewers independently extract the data from the studies, basically all aspects around the training and evaluation, and to identify the impact of the training on either staff, resident, and institutional outcomes. We thought it was important to also include the impact of the training on outcomes, because we don't want to just stop at the quality of the training, but we also want to see what impact the training makes and the usefulness of the training to a broad range of outcomes, in order to allow us to create a baseline understanding of what long-term care training programs, where they are, and if they are equitable, and what impact that they may make. Next slide, please. So our search results were 356 manuscripts, and 29 of these studies were included. Overall, we found that the studies were heterogeneous in almost all aspects of the training, including content, who taught the training, how long the training was, how it was measured, the different outcomes that were used. So actually the absence of these commonalities was quite striking, except one thing that we did notice is that all of the studies took place in high income countries. So they took place in places like Canada, the US, Norway, Sweden, France, Australia, the UK, and Taiwan. And so from our small subgroup, this brought up a lot of, in our conversations, we discussed a lot about disparity and inequity when it comes to being able to even examine the landscape of what's happening in training in long-term care across the globe. Despite this, we did find that there were positive impacts of training for the majority of the studies. So this included staff outcomes such as improved knowledge, improved confidence, more positive attitudes, resident outcomes as well, like increased quality of life for residents, a decrease in infection rates, overall improvement in dementia status and reduction in agitation and other behaviors, as well as institutional level outcomes like decreased infection rates across the institute and an increase in the number of institutionally documented care goals. Next slide, please. So from our review, we were able to see that there was no current measure in the literature that would allow the comparison of training provided in long-term care, in the long-term care sectors on a macro level. So which regions had training, which regions didn't have training, in order to compare between countries, within countries. And so based on the findings of the review, we were not able to use any of the tools that were identified in order to aggregate and help build knowledge about training in general. And that we found that really the most basic information about training, like whether or not it was even provided and whether or not it was even evaluated, would be missing if we try to extrapolate this on a global scale. So we concluded that there is a greater need for more rigorous evaluation of training, as well as a greater really essential foundational baseline understanding about whether training is even provided and whether or not it's even measured across different jurisdictions and countries. And we think that being able to understand this will allow us to understand inequities, start to address inequities by folding countries that are low and middle income into the landscape and into research, and more accurately capture training around the globe as well. So through our conversations, as a subgroup, we acknowledged many different things when trying to come up with what the CDEs could be and what our items might look like. And the things that we talked about were, we first acknowledged the discrepancies in resources and staffing, as well as the differences in system priorities between high, middle, and low income countries. And so it was important for the CDE items that we proposed to be feasible, to be applicable in a multitude of sociopolitical conditions. Further, we recognized that due to differences in languages, the CDEs needed to be really clear. And so if they included very nuanced concepts that were perhaps very complex and more theoretical, they might be lost in translation when being translated from an English concept into another language. So, for example, self-efficacy. So that's a very common Western notion, but it might not be easily understood in other countries, and it might not be considered relevant. So the proposed CDEs needed to be very simple, they needed to be very clear, and also have face validity in order to have buy-in from understaffed or under-resourced settings. We also thought a small number of very easily understood but meaningful CDEs would be more readily implemented across high and low middle income countries. And we also thought that this would, by making it easy to understand, easy to implement, we can start to address some of the inequity within the measurement of this concept. Next slide, please. So from our We Thrive subgroup discussions that I had just described, it became evident that the proposed CDEs needed to collect essential baseline data, because that type of data didn't exist from what we found in the literature. And so this speaks to the presence of and the measurement of the training in order to conduct cross-country comparative research, because currently there is no such macro level measurement infrastructure to compare long-term care settings between countries. So to this end, our two suggested candidate CDEs to begin laying down this groundwork is, was there institutional training provided to staff in the last year? So similarly to Francesca's items, we did put a timestamp on it because it is important to be updated with the most recent evidence. So Was their training provided in the last year? Yes or no? And then was the training evaluated using some type of standardized measure? And it could be related either to staff, resident, or institutional level outcome. And those are 3 yes or no questions. And so we believe that the CDEs simply focused on the presence and measurement of training do help fill a current measurement gap, that these are fairly accessible, they're feasible, and they're not resource intensive to answer. We think that it's important to note that these are proposed CDEs and that they are subject to change according to emerging literature and future ongoing consultations with the broader community and long-term care providers as well. And that further work is required to test feasibility. So we ambitiously want to address measurement and, which is in the second question, but we do have to evaluate the feasibility as well. Next slide, please. So here we have 2 questions in the poll just to gauge the relevance of this concept and the proposed CDEs that are shown here on the screen. So these are the 2 CDEs that I just covered. So the first question is, what do you think about this measurement of staff training for international comparison?
Great, and I see people clicking. I'm going to give another second so we have this similar number of attendees answering or voting. I will close it now. And here are the results.
That's great. I would prefer additional items. For anybody who said that they want more items, please contact me so we can have a conversation and perhaps fold you into the work that we're doing in our subgroup. Judy, can you go to the next question?
Sure.
Excellent. And so the next question here is long-term care staffing sufficiently important to collect data on internationally? So should this even be included in a CDE? Yes, not sure, or no?
People are clicking quickly here. Okay, good. One more second and I'll close it. Got a good percentage now, voting. Great.
Wonderful. Okay, we're on the right track. Thank you, everyone. So I'm going to pass the baton on to Michael.
Thank you, Charlene, and thank you, Francisca, as well, both for your eye-opening presentations. It's wonderful to see this international work, and thanks to everyone for participating in the polls. It's really valuable to get this input along the way. So although long-term care staffing, and we could actually go to the next slide, Judy, long-term care staffing has been a challenge in many countries for a long while, and staffing, however, continues to be examined unsystematically and inconsistently across countries, and even within countries, such as between different types of long-term care settings, like in the US, nursing homes and assisted living facilities. The data collected therein differ quite substantially. Internationally shared common data elements would provide opportunities to integrate knowledge across long-term care studies, across long-term care settings, and across countries, of course. And as these previous studies that were presented show, to, I think very importantly, parsimoniously capture key information on staffing practices and workforce outcomes. Although, as the poll indicated, in some cases, additional items will be valuable to include. I think the emphasis on parsimony and capturing key information with a few limited amount of data is important for the international feasibility. We can go on to that next slide, please. So in addition to the 3 workforce and staffing concepts that were discussed today, we have identified additional staffing concepts, workforce and staffing concepts, including staff attitudes and skills, collaboration and teamwork, and leadership, all of which have been prioritized by an international group of collaborators for identifying proposed common data elements. So as we shift to the question and answer period and discussion period, please share your ideas for these other workforce and staffing concepts and how they would be valuable to measure across long-term care settings internationally. This is work that we still have up ahead, and we welcome everyone's input and engagement on that. We could go to that next slide, please. And actually, we'll be really brief here to get onto that Q&A, but I would reiterate that WeThrive's goal is to internationalize research and to provide comparable data that can effectively inform long-term care policy and practice across countries. We could go to that next slide. And just as a final note for me, I would emphasize that WeThrive is an open network with a wide range of research activities underway. You are encouraged to please make contact if you are interested in collaborating or being engaged in WeThrive research efforts. The WeThrive email address is provided there on the slide, and all are welcome. We are especially interested in the engagement of partners from countries with lower income economies, as well as students. But as the presentation showed, there were sections of the world that were underrepresented or not represented in some of this prior work. And so ensuring broader representation, especially among folks from lower income economies and from students, would be wonderful. So we do encourage folks to become engaged. And we can go on to that next slide, and just a final thank you for everyone for attending, and to Charlene and Francisco for your great presentations. And I think we could shift to the discussion and to the participants and any questions we can address in our remaining time.
Great, sounds good. Indeed, yes. So just a reminder that you can type and send questions using the questions feature in the dashboard. Probably find that on the right-hand side of your screen. We're not using the raised hand feature today. So if you have a question, we please ask you to use that questions panel and type them in. And also another friendly reminder, we are recording the session, so we'll send you an access link by email once that's available. And final note, please also know a webinar survey will automatically launch after the webinar. So in an effort for continual improvement, we'd love to hear your thoughts. And we ask you to please provide feedback by clicking that survey link at the end of the webinar. So that'll follow up after our Q&A session. I think there are some questions being typed in right now. While those thoughts are being completed and submitted online here, I've got a quick question for the group, and then I'll hand the microphone over to you, Michael, to facilitate the questions. But a quick one here. What do we do about staffing in different countries?
Well, that is a big and important question, and I really appreciate both Francisco's and Charlene's work toward helping us sort of grapple with that big question. I think what some of the work has found, and I think Charlene's the later points that Charlene made around the lack of consistent information about especially staff training that's available internationally. I think that does potentially highlight that sort of increasing knowledge about how staff are trained, either that is upon hiring or before hiring, and then during the period of employment and ongoing. I think as far as training goes, that's an important issue. But I think above and beyond that also is the question of the availability of long-term care staff. There certainly have been shortages of staff in some countries. And so, before even getting to that question of training, there also might just need to be sort of issues addressed about the availability of long-term care personnel, and that also might relate to the public image of long-term care settings, which at least in some countries has taken a pretty negative hit in the recent months of the pandemic, where these settings might seem even more unsafe to work in than they did previously. So I know that's quite a wide-ranging response. I welcome Charlene and Franziska to share additional thoughts.
I think a big challenge here is basically we would want to know for nursing homes and also have international answers. So what kind of staff with what education and in what numbers do we need to actually be able to provide good quality of care? But if we look at all these studies that look at these relationships, the big challenge is, so a bachelor educated nurse in the Netherlands is not the same as in Switzerland or in the US, because they have different scope of practices. So how do we compare that? And it's not only at registered nurses, bachelor or master level, it's also at the care aide level. In Switzerland, the care aide can have a 2-year education, or she can have an on-the-job training for 10 days. So whatever kind groups we build and then want to compare between countries, we have a huge challenge there. And this, I just think this is just still a huge task ahead of it if we want to have common data elements, to find a way to make these staffing groups comparable. But we are far away from that.
I think Franziska and Michael both did an excellent job sort of covering the broad area of your question.
And I would share, I am able to see one of the other questions that has come in, and I think we could all touch on this perhaps. The question is about any work that is being done to collect common data from national or other sources, such as the demographic characteristics of staff. And yeah, I'm not sure, Charlene or Franziska, if you could speak to that from your work here or your knowledge otherwise.
Charlene, do you want to start?
I was waiting for you to start. I didn't want to talk over you.
Well, I have to admit, I think it's not as far advanced in long-term care as studies in the hospital sector, where we do have international studies looking at the same data. But in long-term care, in these demographics, I have to admit I wouldn't know. I always suffer from not being able to compare data.
I just wanted to add that I think that this is a problem, and one of our We Thrive steering committee members, Elena Segal, is currently writing a paper addressing some of these issues about even the kinds of staff, how many staff, and being able to even identify who is in the home, because there are so many different names for all different positions. All different positions have different responsibilities and training. And so I think she's conducting some review of really, her and I think another student are conducting a review about all of the potential labels and categories in long-term care. So
thank you both. And yeah, I would agree. This is it's an interesting and important question. And I think it seems like it should be a relatively easy one to solve for. Collecting the demographic information about long-term care staff feels like it should be a sort of a low-hanging fruit. But I think even the sheer differences across long-term care settings internationally poses a challenge to that. One of the four domains that we didn't discuss today was on the contexts of long-term care settings, and just being able to sort of match apples to apples, say, a nursing home in the US and a care home in the UK. Are these the same sorts of places, or are they different places in nature? So even being able to reach consensus broadly on what is a long-term care setting has some challenges, and so I think grappling with the staff within is important as well. I see we're just about out of time. I do want to say I see a couple questions, and I'm especially enthusiastic to see one about opportunities for doctoral students and postdocs to be engaged. I think Charlene could speak to that really well, but all I would say is we would highly welcome, and there's lots of opportunities for collaborative work. And I'll pass it off to Judy to help wrap us up now.
Thank you so very much. I'm sorry we have run out of time, but please know that I'll share these unanswered questions with the panelists and round back with the attendees. Charlene, Francisca, and Michael, it's been a real pleasure learning about common data elements for workforce and staffing in international long-term care research. And we thank everyone for participating. This is the end of the program.